Alrighty, thank you, Allison, and thanks everyone for joining. The Center for Medicare and Medicaid Services, CMS, published the final Medicare Physician Fee Schedule rule in 2015 late last month. The rule brings a number of changes that doctors and practice managers are going to need to understand about a number of different areas. Today's webinar, we're going to center around understanding of these changes, how it's going to impact your practice. First, we'll do a quick review of the Physician Fee Schedule, discuss key provisions, understand the impact of these provisions by specialty. I want to take a moment to examine changes in the Physician Quality Reporting System, PQRS, and the value-based modifier, and then conclude with some additional changes that CMS has introduced, one of them being specifically the changes to the 59 modifier. Because there's going to be a lot of information thrown at you in a very short period of time, we're going to include a list of resources at the end of this webinar that you can use for further information. So with that, let's go ahead and get started. So just basically, the Medicare Physician Fee Schedule replaced the CPR charge system, which was, for customary, prevailing, and reasonable, also known as reasonable and customary charges. It's the formula that's used to determine reimbursement amounts. And on the surface, the calculation is pretty straightforward and simple. However, how they get to the foundation of the calculation is a little bit more complex. And this is what goes into funding, Medicare Part B services for providers. The fee is composed of costs associated with the physician work, practice expense, and professional liability insurance. Each of these elements is assigned a relative value unit, which is composed for each CPT code. The work RVU component is going to reflect the relative time and intensity associated with furnishing the Medicare services, and it's typically going to account for around half of the total payment associated with the service. The practice expense RVU reflects the cost of maintaining the practice, such as the cost of supplies, drugs, equipment, staff costs, and then the malpractice RVU then reflects the cost associated with the liability and malpractice insurance associated with the level of service that's required for that particular service being offered from the patient. These RVUs are then adjusted based on the Geographical Practice Cost Index, also known as the GPCI. And the GPCI accounts for the geographical variations in the cost for practicing medicine in different geographical areas of the country. So as for New York and California, the cost is going to be higher for providing the same service than it would be for, say, a practice located in the Midwest. And then the sum of these is then multiplied by a dollar conversion factor. The statute specifies the formula in which the conversion factor is updated is done on an annual basis. The formula specifies for the updates in each year be equal to the Medicare Economic Index. And then it's adjusted up or down based on what the actual expenditures compare to, on how they compare to the target rate, called the sustainable growth rate. Now, the sustainable growth rate is calculated using a couple of factors based on medical inflation, projected growth in the domestic economy, growth in the number of beneficiaries in the fee-for-service Medicare programs, and then specific changes in laws or regulations. In recent years, Congress has taken action to try to establish specific updates amounts for the SGR, and we're going to talk a little bit more about that in the coming slides. So as stated previously, in 2015, the Physician Fee Schedule ruling brings a number of changes that doctors and practice managers are going to really need to understand. Now, instead of having you go through the 1,100-plus page document that was disseminated, we've pulled a lot of the key provisions out, which I want to discuss today in the current slides that are listed here. So first, let's talk about the sustainable growth rate. The Protecting Access to Medicare Act of 2014 provides for a 0% update, neither reduction or increase, of the Physician Fee Schedule for services furnished within the first quarter of 2015. However, the current law does require that Physician Fee Schedule rates be reduced by an average of 21.2% starting the second quarter of calendar from the 2014 rates, starting in the second quarter of 2015. Now, in the most prior years, Congress has taken actions to avert these large reductions. We won't know really until probably the first of the year whether or not that's going to be the case, but as it sits right now, the law requires for a 21.2% reduction starting in the dates of service for the first quarter or second quarter of next year. Now, the administration does support the legislation on permanently changing the SGR, and this is going to provide a more stability for Medicare beneficiaries and providers while promoting efficient and high-quality care. It's very important to get our arms wrapped around the SGR and get that sustainability to where we don't spiral costs out of inflation and not be able to support the Medicare program in future dates. So in looking at primary care and chronic care management, starting in January 2015, Medicare is going to start paying providers to coordinate care of Medicare beneficiaries. This is a significant policy change in response to growing evidence that patients with chronic illness suffer from disjointed and fragmented care. Now, this is going to cover about 70% of the Medicare beneficiaries now who are still in the traditional fee-for-service Medicare program, and about 30% of those that are covered by HMOs and private health plans. Now, although this already is work that is being done by many doctors on behalf of their patients, they've historically not been paid for it. Medicare is going to begin paying monthly fees to doctors who manage the care for patients with 2 or more chronic conditions, such as heart disease, diabetes, depression. Now, the doctor can expect to receive right around $42 a month for managing the care of the Medicare patient, and the care management services can be provided and billed for only if the patient agrees in writing. This is an important point to ensure that if you are going to supply chronic care management for your patients, that you get them to accept the beneficiary in writing in order to be able to bill for it. Now, one of the things that's going to be just with any other service that the patient is going to be responsible for 20% coinsurance associated with the fee, so they're going to have to pay 20% of the $42. And then Medicare will be introducing new G codes that can be used for billing of the chronic care management services provided to patients with 2 or more chronic conditions. And one key factor to take into consideration when you're looking at chronic conditions, the chronic conditions need to be expected to last over a year based on the care provided. And then the providers are going to be able to bill these once a month. Now, the new care program services can be provided not only by doctors but also by nurse practitioners or physician assistants, and there's other certain health professionals that can also bill for the services as well. Medicare officials are determining and expecting providers to focus on sicker patients or more with a chronic ailment of 4 or more chronic conditions. However, 2 is the minimum amount from a care perspective to meet the criteria to be able to bill for the monthly care management program. Misvalued services is something that the government looks at every year, and in the past years, CMS has been very engaged in a vigorous effort to identify and review potential misvalued codes and to make adjustments either up or down, particularly down, where appropriate. Hip and knee replacements is a good example. In 2014, the Physician Fee Schedule final rule adopted code and valuation changes that actually reduced the payment for hip and knee replacement. The final payments were higher than were actually recommended by AMA and especially Society Relative Value Update Committee. Now, when looking at these, CMS indicated that it would consider further changes, but moving forward, the agency decided further reductions weren't warranted after considering public comments, and those are actually going to maintain the same consistency in 2014, which was a reduction off of previous year. Looking at radiation therapy and gastroenterology, these are consistent with final rule policy, and in response to public comments, CMS is not adapting code changes for gastroenterology and radiation therapy services until it can go through more of a final notice period and comment rulemaking that is subject for 2016. As a result of this decision, CMS is not going to recognize any of the new CPT codes and will be creating a new G code in place of the current CPT codes to continue current payment rates for the calendar year 2015. These new codes are supposed to be introduced January of 2015. For radiation therapy, CMS proposed to refine the way that it's accounting for infrastructure costs associated with radiation therapy equipment. And they're specifically looking to remove the radiation treatment vault as a direct expense when valuing radiation therapy services. Again, after looking at public opinion, the agency decided not to finalize the proposal. So it's going to reconsider whether or not the vault is a direct or an indirect cost associated with the service, and that rulemaking will be looked to be done in future years. Anticipated at the end of 2015, early 2016 to get a final ruling on that. And looking at epidural pain injection, CMS reduced payment for these services in 2015 under the evaluation. They actually proposed to raise the value in 2015 based on prior resource and inputs. The final policy is proposed is to eliminate the actual guidance associated with this. So they're going to maintain the rate for the epidural injection, but they're going to bundle the payment and make it inclusive for any type of diagnostic image guidance associated with the pain injection. Looking at film to digital distribution, this is where CMS is finalizing a proposal that the agency practice and looking at services and understanding the expense associated with radiology services to where x-rays are typically done more in a digital format rather than an analog format. In looking at global surgery, changes are expected in the coming years. The OIG has identified a number of surgical procedures that actually include more visits in the global period than are actually being furnished. They've considered the post-surgical visits that are valued higher than visits that were furnished and billed separately by other physicians such as general internists or family practice providers. And the proposal is to transform all 10 and 90-day global periods to 0 global days beginning in 2017. Now, after consideration of comments, CMS finalized the proposal beginning with the 10-day global period in 2017, and following that in 2018 with a 90-day global service period. It stated that in the reevaluation services, a 0 global day period will actively assess whether there is actually a better construction of the bundle payment for surgical services, and that's going to incentivize the care coordination and the care redesign across the entire episode of care as they care for the patient. Telehealth services are really starting to advance within CMS, and they're adding the following services that are listed here. As part of those, they're going to be furnished now for Medicare beneficiaries under the telehealth benefit, annual wellness, psychoanalysis, and therapy, and then the prolonged evaluation and management services will now be covered for Medicare beneficiaries under the new provisions in 2015 fee schedule. Excuse me. In looking at malpractice RVUs, as required by law, Medicare actually will review and, if necessary, make adjustments to the malpractice RVU, and the law states that it will happen no less than every 5 years. For 2015, CMS conducted its third comprehensive review, and it has made updates to the malpractice RVUs and proposed new malpractice RVUs for all services. They're adopting new resources based on malpractice RVUs that is the basis of updated professional liability insurance and premiums that are largely paralleling the methodology they used in 2010. So we are going to see increases in the malpractice RVU component taking into account the increased professional liability that we have moving forward. Also, which is required by law, Medicare is going to be making adjustments and differences in the operating of the geographical practice cost index. For 2015, CMS is using territory wage data to calculate the GPCI for the Virgin Islands. Also in 2015, the GPCIs reflect the application of statutory mandate of the 1.5 work floor GPCI in Alaska and the 1 work floor GPCI for all physician fee schedule areas and frontier states such as Montana, Nevada, North Dakota, South Dakota, and Wyoming. However, given the statutory 1 GPCI work floor, this is scheduled to expire at the end of the first quarter of 2015, and the GPCI is then going to reflect the elimination of the 1 work floor GPCI starting in April 1st through the end of 2015. For off-campus services, CMS has been collecting data on services furnished on off-campus provider-based departments, acting as a department of the hospital, and it's going to require to report a modifier for these services furnished in off-campus provider-based departments, and require physicians and other billing practitioners to report these services using new place of service codes on professional claims. Now, data collection is going to be voluntary for hospitals in 2015. That's going to be mandatory in 2016. And the new place of service code will be required for all professional claims being performed in an off-campus provider-based office starting in 2016. So the new codes will be available at the earliest in 2016 and can't be used before then. In looking at the open payments program, this is going to require applicable manufacturers of drugs, devices, and biologicals, as well as medical supplies, to report payments or transfers of the value that they make to physicians and teaching hospitals to CMS. In response to a lot of the questions associated with the open payments, CMS is making 4 finalizing changes to this current rule. They're going to be deleting the definition of covered device as it is duplicated with the covered drug, device, and biological and medical supply, which is already defined within the regulation. They're going to be deleting the continuing education exclusion in its entirety. Eliminating this exemption for payments to speakers or certain accredited or certifying continuing medical education events is going to create more of a consistent reporting requirement and will be more consistent for consumers who ultimately have access to the reported data in the future. CMS is going to start requiring that the reporting of marketed name and therapeutic area or product categories related to drug, device, and biologicals, unless the payment of those transfer values is not related to a particular covered or non-covered drug. And then finally, CMS is going to require applicable manufacturers to report stock options, and any ownership interest in the distinct categories. This is going to enable them to collect more specific data regarding the forms of payments made to these applicable manufacturers. And based on public comment, the need to update the system according to the new requirement changes that will be implemented for data collection in 2016. In looking at my mammography, until now there hasn't been any separate codes that allowed for the payment of the higher cost 3D mammography imaging as compared to the 2D mammography imaging. Since 2000, 2D digital imaging has been paid at a special payment rate and typically provided by a law for digital mammography. To ensure that the higher resources needed for 3D imaging are recognized, CMS is paying for 3D mammography services using add-on codes in 2015 that will be reported in addition to the 2D mammography codes. And then they're going to revisit the payment for 2D and 3D within the calendar year of 2016 under the Misvalued Code initiative that we discussed earlier to make determination on the appropriate reimbursement for those services as it relates to the cost of the 2D and 3D imaging in future years. In the ruling, CMS estimates that the payment impact of the Physician Fee Schedule services on these proposals contained in the proposed rule are going to operate on a year-to-year changes. And you can see some of the impacts here to some of the specific specialties on the increase or the decrease in the estimated reimbursement moving forward for the different specialties associated with the 2015 Medicare Fee Schedule. With PQRS has had evolving changes over the year. Now moving forward in 2016, there will be no bonus payment for successful participation in the upcoming calendar year. And for those providers that have not successfully participated in 2015, you're going to see a reduction of the 2% Medicare reimbursement for non-successful participation. For 2015, there are 28 new individual measures that are being added, and they're removing 73 of the total 240 measures, as well as 2 new group measures that are being added. So for all eligible providers, it's important to make sure the qualification within 2015 is done from a participation standpoint to mitigate the need for Medicare to take the 2% reduction in reimbursement starting in calendar year 2016. Associated with the PQRS initiative and the value-based modifier for group and solo practitioners, they're going to start the classification of these groups for 10 to 99 as well as solo practitioners. There's going to be subject to the 2017 calendar year value-based modifier. So increasing the upward adjustment from 2 to 4% and increasing the maximum downward adjustment to 4% as a max associated with groups and solo practitioners classified as a low-quality provider with a high-cost association. They're going to set the adjustment to 2% for groups and solos where there is a low-quality average cost or an average quality and high cost associated with the services rendered. And they're going to increase the maximum upward adjustment to 4.01% for those providers that have high quality and low cost. New group categories of 2 to 9 providers will receive only the upward or neutral adjustment, and the year's groups of 10 to 99 providers will face upward, neutral, or downward payment adjustments associated with the average quality and low cost. So the higher the quality and the lower the cost, the higher the increased reimbursement. The lower the quality with the higher cost, the more the maximum adjustment is going to be seen moving forward in calendar year 2017. The good news is Medicare is now going to start covering annual wellness visits, providing personalized prevention plans for services at no cost to the patient. Now, this is a new benefit that's going to provide ongoing focus on the preventative care of the patient. The annual Medicare wellness visit provides for an opportunity for the healthcare provider to be reimbursed while providing the necessary preventative care to their patients. The welcome to Medicare is only payable once within the first 12 months of the patient joining the practice, or within the patient joining the Medicare as a Medicare beneficiary. The initial annual wellness visit is payable once per lifetime. The average reimbursement is $172. The annual wellness visit must be performed by a physician or a qualified non-physician practitioner, which is under the supervision of a provider. And the required documentation is to collect self-reported information about the patient. You need to tailor and to take into account the communication of the patient and take no more than 20 minutes to complete the visit. And it should address things such as demographic data, self-assessment, health status, psycho and social risks, behavioral risks, activities of daily living, and instrumental activities. Now, the subsequent annual wellness visit, the GO439, is payable once every year. The average reimbursement rate is $111. As it related to the preventative visits, it's important to market to your patients as well for those Medicare beneficiaries who have not been seen in the office for their annual wellness visit. It's a way to ensure that we're providing appropriate preventative care in the time care continuum, but also an opportunity to increase some of the reimbursement for your individual practice. One of the other changes that's significant in the provision and changes for Medicare is the change of the 59 modifier. These changes are going to be implemented January 1st, 2015, and it's going to include 4 new modifiers to really allow specificity and more granularity into the coding process for those procedures where the providers are saying that they're separate and exclusive. These are performed more or referred to as the ESPU modifiers, and they're going to require providers to specify the circumstances that call for the separate reimbursement that was historically used at the 59 modifier. CMS is still going to continue to recognize the 59 modifier. However, they are going to be looking for more descriptive modifiers to be used, and I would anticipate that, even though they are going to recognize the 59 modifier as the modifier is billed to Medicare starting January 1st, 2015, I would anticipate a higher level of denials to be accentuated requesting medical records or requesting a more specific modifier moving forward. So within the Modifier-X ESPU, I want to kind of slowly mention over each of the increased modifiers. So the XE is going to be that of a separate encounter, and this is going to be a service that's going to be distinct because it physically occurred in a separate encounter. And as we go through, I have some specific examples of where these modifiers would be utilized best. The XS is the modifier that should be used for a separate structure. Now, this is a service that is distinct because it is actually performed on a separate organ or a separate structure within the body. A separate practitioner is just that because it was performed by a different practitioner within the same episode of care. And then unusual and non-overlapping services. The use of these services are distinct because they don't overlap with the usual components associated with the main service that was provided. So in looking at some specific examples, the XE would be utilized when a patient receives an outpatient infusion. They leave, they come back later and receive another dose of the infusion of antibiotics. Since these occurred on two separate instances or two separate encounters at the same day, it would be appropriate to bill with the XE modifier to indicate that the services were performed within a separate encounter. An example of a separate structure would be where a skin lesion on the arm was destroyed by a laser, and then within the same episode, another lesion would be biopsied off of a leg. Since these are two separate structures, the arm and the leg, the XS modifier would be appropriate to reduce the bundling and the NCCI edits associated with the inclusive procedure and indicate that that service was performed on a separate anatomical site. For the XP separate practitioners, this would be an example of where one provider performed a laparoscopic hernia repair earlier in the day, and then later in the day, due to complications, the patient needed to have a laparoscopic appendectomy that was performed by a different provider. Since these were performed by different providers during the same day and episode of care delivery, it would be appropriate to use the XP on the appendectomy procedure in order to be able to designate that these were exclusive because they were performed by separate providers during different episodes during the same care process. And XU is a little tricky, and this is utilized for identifying unusual and non-overlapping services. Examples of this would be where separate lesions are present that would not within the same code set, such as a lipoma being excised on the upper thigh and a separate lipoma being excised on the lower thigh. Where the lower thigh was used in a separate area, an XU would be appropriate to identify that these are non-overlapping services. So what is this going to mean for you? As of January 1st, 2015, claims are going to be accepted and processed by Medicare containing these new modifiers. Within the MD Everywhere application, we have applied edits for those claims that would qualify for the XPSU in the same manner that those edits would apply for lines containing the 59 modifier. And then I would really anticipate to see an increase in denials related to the documentation, as I've mentioned earlier, to support the specificity associated with each of the modifiers. Even in using the new modifiers, I would anticipate that we're going to start seeing rejections and requests for medical records to be able to clearly articulate within the documentation that those were done for separate services, whether it be within a separate encounter provider, non-overlapping services, or a separate structure. So as mentioned previously, here are some of the resources that we've listed here at the end of this presentation and webinar reviewing the 2015 changes in reimbursement in the Medicare Fee Schedule. And I believe Allison will go into more detail on some of the white paper initiatives that we'll be sending out as well that will have even more specificity about some of the items that we covered today. I want to thank you all again for joining, and I'll hand it over to Allison.